So it's my pleasure to introduce Dr. Ekaterina Malievskaia. She's a physician, but more importantly, she's the co-founder of Compass Pathways. I think originally as a non-profit, which you then transformed to a profit. And of course, everybody's talking about their program in treatment-resistant depression. Now, today we are in the philosophy tract, and she will talk about how can psychedelics create a more integrated and patient-centric approach to mental health. Katja, please.
Does it work? Yeah. Hello, everyone. Thank you very much for the introduction and for the opportunity to speak at Insights. As was mentioned, I am a physician. I was trained in internal medicine and was in private practice, academic medicine and mental health for many years. And in my practice, I wrote a lot of prescriptions for antidepressants. And to my regret, I never thought what happened to patients when I would refer them to psychiatry. And only when our family became on the receiving end of mental health care, I was struck how many opportunities for excellence there were in the field of psychiatry. We thought, how hard could it be? It's just depression, it's just OCD. And frankly, in my professional life, it was one of the most difficult things to do, to find help for the family member with depression and OCD. And I think that's what inspired us to start the company. As you rightly said, we started as a nonprofit, but after the scientific advice with the European Medicines Agency that guided us towards the diagnosis of TRD, we realized that we will never be able to accomplish that goal as a nonprofit and transform the organization into for-profit. A side note, we never raised any outside money. So we've created Compass as we created Compass with a mission to accelerate access to evidence-based innovations for patients living with serious mental illness. And that was the mission of nonprofit and the mission of for-profit, and that's how we set our strategy, that's how we make our decisions every day. And we stand by this mission. And as a result of that, we think of ourselves not as a psychedelic company, but as a mental health care company. And the main distinction is that we are inspired and motivated by significant unmet need, by patient suffering, and much less by allegiance to a particular drug or the class of drugs. And with that, I want to mention that not to diminish the impact of existing socioeconomic structures on health, general health and mental health in particular, but we have chosen to work within existing structures, within existing health systems, and within existing economic and policy structures and frameworks. So by itself, it's not the endorsement of the systems, but with all its flaws, these systems were designed to scale innovation, to scale approved treatments, because innovation is not a great idea that can transform the world. Innovation is that idea operationalized to the point where it can create value for hundreds of thousands, if not millions of people. So with that in mind, we've created Compass, and this is our target population. This is the photograph of a self-portrait of a Norwegian photographer, Lena Marie Fossen, who, as a photographer, worked documenting the plight of migrants in Southern Europe. And alongside with that, she also documented her own struggle with anorexia. She died of anorexia a few years ago at the age of 36, have been suffering for this for 25 years. And there is a really nice documentary about her where she said something that stuck with me, where she said, "You treat my symptoms, but I'm a whole person." And I look at this photograph often when we're stuck, when there are difficulties and difficult to move forward. I look at it and it gives me additional motivation. And I also think it's a really nice, as difficult as it is to look at it, I think it's a nice representation of what mental health would look like physically, phenotypically, if there were physical manifestations. But there are millions of people walking around with treatment-resistant depression, OCD, bipolar disorder, borderline personality disorders, and you cannot tell how much they suffer. It's invisible. Anorexia, I think, is one of the very few mental disorders that you can actually see the physical manifestations. So this is our population. With that in mind, because of the way we have chosen to work and because of the population that we have chosen, there are a few ethical considerations of applications of psychedelics within the framework of mental health care. And in no particular order, first I want to say that the allegiance to traditional practices, to century-old practices, is very strong in psychedelic research and psychedelic practice, including, in studies and study design and interpretation of the results. And I think these conversations just started, and we need to continue, and we need to find the solutions for how to ensure scientific and clinical equipoise, and we need to work together on that. So the contents of the sessions, the motivations of the therapists, the motivations of researchers, the personal convictions, ideological, religious, or spiritual convictions, they all play a role in outcomes. That's just for research, but when we talk about implementing this novel models of care into national health systems, integrating it into national care guidelines, it becomes even more problematic when we work with a population that is marginalized, disadvantaged, and overall vulnerable. So any intervention that is, or any mode of care that is implemented in national health systems or national care guidelines or on a broader population scale need to be assessed, and we need a very robust evidence in order to ensure patient safety and efficacy, in order to be able to market these treatments and be honest with patients. So the quality of evidence matter. And another thing that matters is access. Access, I know, I've heard, through this conference, I think it became an overused word, and it's used for access to psychedelics, access to mental health care interchangeably. I don't think it's the same thing. I think access to mental health care is not possible without reimbursement, and integration into national care guidelines and national health systems is not possible without the highest quality of evidence. Those are the studies of comparative effectiveness and maintenance of response, relapse prevention, longevity of the effects. Those are very large, very difficult, and very, very expensive study. There was a paper, I think it was a study or review in JAMA several years ago, I think maybe 6-7 years ago, that showed that the higher the quality of evidence, the more expensive the studies are. Not another way around. We know a lot of very expensive studies that have very low impact. But I think for the purpose of access, what we need to understand is that regulatory approval is not the end, it's just the beginning, and we will need to continue doing research, high quality research, in order to ensure access. Now, what is the unique value of psychedelic treatments and how they could be integrated into mental health care for the 21st century? I think the idea here is that we should, leave no stone unturned, going back to the evidence, no stone unturned, and question and test and retest, practices, not simply, transplant them from 50s and 60s into modern research and modern practices. And with that in mind, let's reimagine what the mental health care for 21st century would look like and what role psychedelics would play in it. So first of all, psychedelics as a molecules offer a rapid, almost immediate onset of action that is, and the effect is sustained for weeks or months, sometimes years after initial administration. It's a one-off administration. That's a unique paradigm. But all the kind of obvious benefits aside, that patients don't need to wait 12 weeks and we don't need to guess, and the compliance issues are sort of non-existent. What I think psychedelics offer is a unique research tool. They offer a compressed model of disease. The patient is depressed, took the drug, undepressed the next day, and maintains response and remission. And this attribution of effect to psychedelics offer a very interesting paradigm for research, because we can look at a variety of novel exploratory markers alongside with established regulatory accepted regulatory endpoints. And that would include moving beyond receptor occupancy, and that would include moving towards circuit-based markers, EEG, speech and biomarkers, voice recognition, probably to characterize such complex states as mental illness. We would move towards composite markers that would encompass all of available markers. And identifying these composite markers, we might be able to take a different approach to the diagnosis of mental illness and recognize unique disease subtypes that would allow us eventually stratify patients for treatments that they are most likely to respond immediately. That way, we don't need to, take a last century approach. Let's try antidepressants, they're really cheap, and see what happens. And in 6 months, let's reevaluate and see if we can move to more effective treatments. So I think understanding these mechanisms of what works for whom and when is one of the most value propositions of psychedelics as a research tool. And it would also enormously de-risk drug development and lead optimization in drug development. So I guess what I want to say is, this is not even, in business world, is not even a forward-looking statement. It's sort of the statement looking around the corner. Statement. I think the future is not in all-encompassing blockbuster drugs. The future is in blockbuster care pathways, where highly personalized approach to individual needs of patients is recognized, well-defined by understanding disease subtypes. And I think the future is in our deep understanding of pathophysiology, phenomenology of the experience, phenotype of disorders, and creating a suite of interventions, psychedelics or not, in various combinations that are suited for a particular patient. That would really transform patient care, patient access to high quality care. Now, moving to mechanism of action and mechanism of change. I think mechanism of action is now well understood. I think the chase for the next generation psychedelics is slightly misguided. I think we do need to understand disease subtypes first before we, try to, we don't quite know what to do with molecules that we already have. But I think the molecules are actually the least innovative and interesting part of what psychedelics can offer. There are two things that we know: that the particular type of psychedelic experience matters in patients' outcomes. It determines patients' outcomes. It also determines the longevity of the effects. But we also know that the patients value their experiences. It could be horrendous, they could be unitive, they could be blissful. They value these experiences regardless of the emotional valence. And what is therapeutic, subjectively therapeutic in these experiences, is not well understood. I don't think it has been, this question has been asked, but I don't think it has been studied and answered adequately. And therefore, I think it's premature to superimpose any psychotherapeutic techniques, whether they're evidence-based or not, on the existing, ongoing psychedelic experiences. before we understand the underlying psychological mechanisms. So our approach in clinical research and clinical development program is to strip down the psychological support of patients going through this experience to the needs of bare safety, to ensure patient psychological and physical safety, so we can actually study these psychological mechanisms and understand without it being confounded by therapists' personal preferences, their training, their convictions, their experience. And that said, I think therapy optimization research, once we understand these mechanisms, therapy optimization research will be one of the most promising frontiers of psychedelic research. And that's, I think, where the money is, frankly, figuratively speaking. I think about it not, whether it's in clinical care terms or regulatory terms. I don't think of it as drug therapy combination, and it's a matter of just figuring out whether it's ACT, humanistic, or transpersonal psychology. I think of it as an amalgamated approach that probably doesn't have the name yet. When I'm thinking about it, and it's going to date me, I'm thinking about when the automobiles were invented. There was no word for automobile, and they were called horseless carriages. Or when the radio was invented, it was called wireless. We still have wireless. But I wonder if that is a new modality that really doesn't have the name yet. And that's why we need to be very careful studying it and understanding it well before we start, messing with it. So on this path, when I think about this combination or this amalgamated approach, I remember what one patient told me very early in my explorations. That person told me that psychiatry doesn't utilize one of the their main resource, the most important resource, I have it here. Psychiatry doesn't utilize the most important resource, patient's ability to heal. And it sounds very soft, not for patients. What we see that, the reason why we want to, kind of understand this patient's ability to heal without, additional influence of therapists is precisely for the reason to give this power back to patients. Because one of the main values that this experience offers is patient empowerment. And patients in, our experience with over 500 sessions, patients come out and say, I am not my depression, I am not my OCD. Even if the symptoms come back, I can live alongside of the symptoms. There is no confusion, they're not fused with their symptoms. There is a space and a time where they can choose to engage or not to engage with their triggers, if it's for OCD, and their symptoms, if it's depression. They can live alongside, and that's huge. So this patient empowerment is a subjective experience. I just don't know how much time I have. Subjectively, that's what patients are experiencing. But in terms of healthcare systems, it translates in what's known patient activation. And patient activation is a known framework, is a known approach in chronic disease management. And essentially, what it means is that the locus of control shifts from the provider, from the caretaker to the patients, and they get in touch with their sense of self-agency, and they take responsibility to change, thoughts, emotions, or behaviors that may play a role in their health outcomes. And that is not only empowering to the patients, but it's also hugely empowering and encouraging to, for the health systems in a world of limited resources. And to illustrate this point, I want to tell you the story briefly, a story of one of our patients, a single mother of two, from a very underprivileged background, a string of unfortunate events on public assistance, everything that could go wrong went wrong. And she went through psilocybin sessions. She didn't particularly have, this kind of psychedelic language or the, the kind of ontological, framework for this. But she came out of this experience and she said, I'm an unfinished manuscript and I'm going to go and finish it. And within several months, I think up to a year, she, I think my team can, correct me if I'm wrong. She went on meditation retreat. She picked up the meditation practice. She started exercising to change her diet. She got, I think, her high school diploma and enrolled in some evening classes, completely unprompted. There was no, 7 to 10 integration sessions. There was no, drawing or writing or anything. She just came out of it and just did it. And I think that's a unique value proposition. Doesn't happen often enough, but we need to understand what happened to this patient so we can more predictably replicate it in other patients. So I think I'm coming to the end of my talk, and so I think I'm going to leave you with this thought that integrating these radically new models of care into something, sometimes sclerotic existing health systems, it's not something that one company, one organization, one academic institution, or even one country can do. It will require an ecosystem of academics, payers, researchers, clinicians. Most importantly, patient voices, experts by lived experience, and payers. And that's why I think platforms for dialogues like Insight are very, very important. And here I want to qualify it. There is a difference between dialogue and debate. And debate is when you come with strongly held convictions, prepared to defend them to death and determined to win. And dialogues are when you come with strong convictions, held loosely with an open mind and prepared to learn from others and prepared to change your mind. I think there's a book about it, the whole book about how to change your mind. And I think as companies like USONA, Compass, and MAPS are moving towards regulatory approval of these substances, I want to remind you that the regulatory approval is just the beginning. It's not the end, it's just the beginning. And we all need to think together and be prepared for that. And we need to take a long view with the aim to democratize access to this potentially life-transforming treatments so everybody can have access to high-quality, evidence-based models of care regardless of their ability to pay. Thank you.
Thank you, Katja. Are there questions? Do we have somebody here with a microphone?
Yes, thank you very much. I like how you say you want to empower patients and provide access and democratize everything. I'm wondering, what would you say to someone who says that some of the actions of your company, at least as far as they are visible in the media, might go into a different direction by patenting stuff such as settings of these therapies? Does this really help to spread it and make it more accessible, or is this perhaps excluding others?
Yes, thank you for this question. I think we've responded to this numerous times that we are not patenting setting beige pillows and handshakes. So I think I understand that don't let facts get in the way of a good story. Nevertheless, I'm never tired of repeating it. This is not the case. This is simply not true. Now, patents. It's a bit of a lazy thinking when you think about patents equals restriction. Therefore, it limits access. It's actually another way around. And if you go back to my point about creating a high quality evidence that requires substantial funding. It's the patenting, the IP position that allows you to raise substantial amount of money in order to support evidence generation, and in order to deliver the evidence that is required for ubiquitous access. So it's not, the actions are not, actually they are consistent and they are aligned with the mission statement.
Thank you. More questions? Moritz?
Yeah, thank you for the beautiful talk. I would like to ask your opinion. What are the last studies or questions we need to answer before regulation can pass? What are the most important questions for you?
So I think this question is mostly for regulators. And as a company, we started our path with having conversations with regulators. We've had conversations with regulators, I think, in over 7 different countries. I don't exactly remember how many countries we've spoken to. And one of our very first things that we've done before we even were a grown-up company is to have a conversation, what's called parallel scientific advice, when there are regulators and payers from 28 different member states. At that time it was 28, now it's -1. We all came together to discuss the potential path for development for psychedelics to understand both payer and regulatory perspective. And I think that's what guides our clinical development. Obviously, we're not coming up with our own questions because there are enough questions from the regulators and payers. But first, you show the efficacy, you show safety, and then the next step, post-approval, you show the maintenance of response and relapse prevention. You show cadence of the administration, which is very difficult to study prior to approval, and perhaps that's the question post-approval. But these clinical development programs are closely guided by the regulators. I think in terms of contribution from academics who are not bound by these boring questions that are that serve the purpose of regulatory approval, I think academics can play incredibly important role, and I think the therapy optimization research is a very interesting area that in a collaborative way we can all answer, but there is much more, it's much more vibrant, much more interesting space to be, I think.
Thank you for the insightful talk. I would like to hear your stance or your position towards psychotherapy that might be associated with psychedelic treatment, and how Compass is planning to tackle that. Like, what are the plans of Compass to develop psychotherapy?
So, as I said, our current approach is because we are preparing for the regulatory approval, we're following regulatory guidance. And, I think that it's been said several times in this conference, but the regulators don't regulate practice of medicine, they regulate the drug. And so, first of all, the regulators want to see what the drug with minimal support can do. Payers want to see the same thing for the reasons that the reimbursement for the drug and therapy come from different pockets. So let's not get ourselves into a pickle when we have a complex intervention and they just say, you know what, we can't deal with this. Go away and do another study where you separate drug from therapy. So our current approach is minimal psychological support that is required for patient safety. As I said, the therapy optimization research is very important. That just because we're taking this approach doesn't mean that we want to cancel therapists and it will never happen. I think this dialogue is, this sort of therapy versus drug, psychological versus biological, is a necessary, unhelpful dichotomy. I think it reopens old wounds between psychiatry and psychology. But actually, I see it as an opportunity to finally come to the common solution and conclusion where these two approaches can come together, and one cannot move forward without the other. But to your question, what Compass plans are, I think that our first goal is regulatory approval, and the second goal is to see how we can participate in the effort of therapy optimization research.
Very interesting questions and very interesting answers. We had a workshop together 2 days ago with regulators, and there were interesting discussions about all these questions. And we have different opinions, and the regulators are learning. They change their minds, as you know, in the development process, and that sometimes can be a problem for companies. So I think we have to stop here, unfortunately. The discussion could go on and on, but there is another talk in this room, I guess, at 5:30. Thank you very much again, Katja. That was